Good afternoon, our dear students. Today we continue our cycle of lectures in Propaedeutics of Internal Medicine, and we continue submodule Signs and Symptoms of Cardiovascular System Disorders. And today from this system we have a last syndrome. It is syndrome of heart failure. Plan of our today's lecture. It is to give definition to syndrome of heart failure, to discuss classification, pathophysiology, what is systolic and what is diastolic dysfunction, what is left ventricle failure and what is right ventricle failure, what is cardiovascular response. Moreover, we will talk about causes, risk factors, clinical classification, clinical picture, diagnosis, complication of syndrome of heart failure. And in the end of the lecture, I'll give you USMLE test. Definition. Heart failure can be defined as an abnormality of cardiac structure or function leading to failure of the heart to deliver oxygen at a rate commensurate with the requirements of metabolizing tissues, despite normal filling pressures, or only at the expense of increased filling pressures. Heart failure is defined clinically as a syndrome in which patients have typical symptoms like breathlessness, ankle swelling, and fatigue, and signs elevated jugular venous pressure, pulmonary crackles, and displaced apex beat, resulting from an abnormality of cardiac structure or function. Classification: acute or chronic. It can be for chronic, we name usually congestive heart failure. It can be heart failure with high output and low output. It can be systolic or diastolic heart failure. It can be left heart or right heart or biventricular. It can be dilated or non-dilated. And it can be classified by cause. We divide on ischemic, hypertensive, idiopathic, dilated cardiomyopathy, etc. Pathophysiology of heart failure. In heart failure, the heart may not provide tissues with adequate blood for metabolic needs, and cardiac-related elevation of pulmonary or systemic venous pressure may result in organ congestion. This consolidation can result from abnormalities of systolic or diastolic function, or commonly both. Although a primary abnormality can be a change in myocyte function, there are also changes in collagen turnover of extracellular matrix. Here you see scheme of pathophysiology of heart failure. You see that initial factors that lead to it is volume overload, it is pressure overload, myocardial disease, or rapid heart rate. All these factors lead to poor cardiac output that have two main results. It is decreased renal perfusion and increased autonomic nervous system stimulation. And through these two mechanisms, it goes two main compensatory mechanisms. They take part in pathophysiology of heart failure. First, decreased renal perfusion lead to sodium and water retention that lead to increased blood volume, that lead to diastolic pressure, and that increase right atrial pressure and left atrial pressure. Like a result, it is elevated jugular venous pressure, hepatomegaly, intestinal edema, poor PO intake and GI absorption, and increased left atrial pressure lead to pulmonary edema. And the same results can go through another mechanism, through the activation of autonomic nervous system. It lead to vasoconstriction, increased SVR, pallor, sweating, tachypnea, tachycardia that lead to increased left and right ventricle diastolic pressure, and like a result, other symptoms that we discussed. Here a little bit other scheme. Here in the first part of the scheme you see main risk factors for heart failure and for cardiovascular disease in general. It is you see that the biggest word it is hypertension for today. Hypertension, it is a main cause of cardiac remodeling and one of the main cause of heart failure formation. Moreover, risk factors can be genetic disposition, gender, age, obesity, dietary intake, and neuroendocrine factors. All these factors lead to, on the one hand, hypertrophy, on another, structural remodeling. All these factors lead to systolic and diastolic dysfunction and diastolic abnormalities that during some long time, it usually years, it can be 10 or more years, lead to systolic heart failure and diastolic heart failure. And in moment when it starts systolic and diastolic heart failure, the pathological process become much more rapid. And when heart failure becomes symptomatic with systolic or diastolic symptoms during a much more shorter period, it usually months, it can lead to death of the patient. Usual structural changes, it's not obligatory, but usually we see such picture that in diastolic failure, it usually thick heart walls. It is sign of diastolic heart failure because they are resistant, they can relax completely and lead to abnormal diastole, increased pressure, decreased volume during diastole chambers. And systolic heart failure a little bit opposite. Anatomically, it usually thin heart walls that can't constrict completely, that can't effectively push blood to the aorta, to the lung artery. We understand that it is abnormal systole, and we name it systolic heart failure. What is systolic dysfunction? In systolic dysfunction, with reduced ejection fraction, the ventricle contracts poorly and empties inadequately, leading initially to increased diastolic volume and pressure and decreased ejection fraction. Many defects in energy utilization, energy supply, electrophysiological functions, and contractile element interactions occur with abnormalities in intracellular calcium modification and AMP production. Predominant systolic dysfunction is common in heart failure due to myocardial infarction, myocarditis, and dilated cardiomyopathy. It is structured with the thinner with abnormal constrictive function of myocardium. Systolic dysfunction may affect primarily the left ventricle or the right ventricle. Left ventricle failure often leads to right ventricle failure. Usually they lead to each other in more late stages. It always be biventricular failure. Left ventricle hypertrophy and systolic dysfunction in scheme A, you see that it take the beginning from pressure overload, then it goes to left ventricle hypertrophy and systolic dysfunction, and last, it is left ventricle hypertrophy is a compensatory response to stress-mediated systolic dysfunction. You see the opposite rule when left ventricle hypertrophy lead to pressure overload. And diastolic dysfunction. In diastolic dysfunction, heart failure with preserved ejection fraction, when ejection fraction will be okay, ventricular filling is impaired, resulting in reduced ventricular and diastolic volume, increased end diastolic pressure, or both. Hence, ejection fraction remain normal. Ejection fraction may even increase as a poorly filled left ventricle empties more completely to maintain cardiac output. Markedly reduced left ventricle filling can cause low cardiac output, and systemic symptoms, elevated left atrial pressures, can cause pulmonary hypertension and pulmonary congestion. Diastolic dysfunction usually results from impaired ventricular relaxation, increased ventricular stiffness due to valvular disease, constrictive pericarditis, acute myocardial ischemia, hypertrophic cardiomyopathy, disorders with ventricular hypertrophy, and amyloid infiltration of the myocardium. Abnormal relaxation and increased stiffness are associated with diastolic filling abnormalities and normal exercise tolerance in early phase of diastolic dysfunction. Scheme about this process more detailed you can see in the left on this slide. Left ventricle failure. If we talk about isolated left failure, cardiac output decreases and pulmonary venous pressure increases. When pulmonary capillary pressure exceeds the oncotic pressure of plasma proteins, about 24 mm Hg, fluid extravasates from the capillaries into the interstitial space and alveoli, reducing pulmonary compliance and increasing the volume of breathing. Lymphatic drainage increases but can't compensate the increase of pulmonary fluid. Marked fluid accumulation in alveoli, we name it pulmonary edema, significantly alters ventilation-perfusion relationships. The severe or chronic left ventricle failure, pleural effusions characteristically develop in the right hemithorax and later bilaterally, further aggravating dyspnea. Left ventricle injury leading to structural remodeling and dysfunction in the seminal event in the progression of heart failure. And what about right heart failure? Systemic venous pressure increases, causing fluid extravasation and consequent edema, primarily in dependent tissues, feet and ankles of ambulatory patients, and abdominal viscera. We see in such patients ascites. The liver is most severely affected, but the stomach and the intestine also become congested. Fluid accumulation in the peritoneal cavity ascites can occur. Right ventricle failure causes moderate hepatic dysfunction, with modest increases in conjugated and unconjugated bilirubin, hepatic enzymes, etc. The impaired liver breaks down less aldosterone, further contributing to fluid accumulation. Chronic venous congestion in the viscera can cause anorexia, malabsorption of nutrients and drugs, protein-losing enteropathy, characterized by diarrhea and marked hypoalbuminemia, chronic GI blood loss, and rarely ischemic bowel infarction. Here you see a scheme of pathological process of right ventricle failure. You see that usually it starts from increased right ventricle afterload that lead to prolonged isovolemic construction, increased myocardial wall stress, right ventricle hypertrophy, to shift of the intraventricular septum that lead in its turn to left ventricle failure, to right ventricle ischemia, and decreased right coronary perfusion that worsening each other. All these links can affect each other and be connected in one way and in another way. Moreover, increased right ventricle afterload lead to right ventricle dilation that lead to tricuspid regurgitation that in each turn worsening right ventricle dilation too. And all these factors, all these links lead to right ventricle failure. And what is cardiovascular response? For us, the most important thing in heart failure patient, it is effect of this abnormal pump function of the heart or abnormal dilation of the heart. What vascular effect we have, what target organ affected, what results and what complications we got, why it is one of the most significant killers in the modern world. In ventricular function, if ventricular function is impaired, the higher preload is. The ventricles are remodeled over time. The left ventricle becomes less ovoid and more spherical, dilates and hypertrophies. The right ventricle dilates and may hypertrophy too. Initially compensatory, these changes eventually increase diastolic stiffness and wall tension, including diastolic dysfunction develops, compromising cardiac performance, especially during physical stress. Increased wall stress raises oxygen demand and accelerates apoptosis. It is, you remember, programmed cell death of myocardial cells. Dilation of ventricles can also cause mitral or tricuspid valve regurgitation with further increases in end diastolic volumes. With reduced cardiac output, oxygen delivery to the tissues is maintained by increasing oxygen extraction and sometimes shifting the oxyhemoglobin dissociation curve on the right of favor oxygen release. Reduced cardiac output with lower systemic blood pressure activates arterial barrier reflexes, increasing sympathetic tone and decreasing parasympathetic tone. Heart rate and myocardial contractility increase arterioles in selected vascular beds constrict, venoconstriction occurs, and sodium and water are retained. These changes compensate for reduces ventricular performance and help maintain hemodynamic homeostasis in the early stages of heart failure. These compensatory changes increase cardiac work, preload and afterload, reduce coronary and renal perfusion, cause fluid accumulation resulting in congestion, increase potassium excretion and may cause myocyte necrosis and arrhythmias. Here you see pathological cycle, its scheme of cardiovascular response. You see that it based on left ventricle, first of all, on left ventricle dysfunction. Yes, it can be right ventricle, but it's more rare, and signs mechanism nearly the same, but they are less specific. What about left dysfunction? It leads to TNF, insulin resistance, malnutrition, inactivity. Then both of them lead to catabolic state. Both of them lead to skeletal and respiratory myopathy that, like a result, have a muscle fatigue, dyspnea, and increased ergoreceptor activity. This increased ergoreceptor activity lead to increased ventilation and just worsening dyspnea, like additional pathological link. This ergoreceptor activation in its turn can lead to sympathoexcitation vagal withdrawal that lead to vasoconstriction, increased afterload, and the cycle is returned that lead to left ventricle dysfunction and reduced peripheral blood flow. And this cycle just worsening. As a cardiac function deteriorates, renal blood flow and glomerular filtration rate decrease, and blood flow within the kidneys is redistributed. The filtration fraction and filtrated sodium decrease, but tubular resorption increases, leading to sodium and water retention. Blood flow is further redistributed away from the kidneys during exercise, but renal blood flow improves during rest, possibly contributing to nocturia. Decreased perfusion of the kidneys and possibly decreased arterial systolic strength secondary to decline in ventricular function activates the renin-angiotensin-aldosterone system, increasing sodium and water retention, and renal and peripheral vascular tone. These effects are amplified by the intense sympathetic activation, accompanying heart failure. The process causes a cascade of potentially delicious long-term effects with myocardial and vascular collagen deposition and fibrosis. Vascular and myocardial hypertrophy, thus contributing to the remodeling of the heart and peripheral vasculature, potentially worsening heart failure. Here you see one more time scheme of cardiovascular response in heart failure. First of all, with systolic left ventricle failure and affecting all links. It is kidneys, it is central nervous system, it is inflammatory mechanism with influence of risk factors. Chronic activation of neurohumoral responses is detrimental to the normal balance between myocardial stimulated and vasoactive hormones. Beta-1 receptors are downregulated, probably in response to intense sympathetic activation. Plasma norepinephrine levels are increased, largely reflecting sympathetic nerve stimulation, and plasma epinephrine levels are not increased. Vasopressin is released in response to a fall in blood pressure. Atrial natriuretic peptide is released in response to increased atrial volume and pressure. Brain or B-type natriuretic peptide or BNP is released from the ventricle in response to ventricular stretching. Fewer endogenous vasodilators are produced and more endogenous vasoconstrictors are produced, thus increasing afterload. The failing heart and other organs produce tumor necrosis factor or TNF-alpha. Here you see a scheme of balance between parasympathetic withdrawal and sympathetic overdrive in heart failure patient. And effects of this changed balance, it is heart rate increase, increased inflammation with excess cytokine release, it is nitric oxide dysregulation, and they have pro-arrhythmic effects. Age-related changes in the heart and cardiovascular system lower the threshold for expression of heart failure. Interstitial collagen within the myocardium increases. The myocardium stiffness and myocardium relaxation is prolonged with a significant reduction in diastolic left ventricle function, even in healthy people. An age-related decrease in myocardium and vascular responsiveness to better adrenergic stimulation further impairs the ability of cardiovascular system to respond to increased work demands. Here, changes with aging, yes, changing in young heart, in heart failure patient, and age-related cardiovascular disease. What changes we see here? If in young heart in children or young people, we see that it is normal cardiomyocytes. In more aged people with cardiovascular disease, it is fibroblast infiltration between cardiomyocytes. And you see how it looks like schematically. Causes of heart failure. Heart failure can complicate any cardiovascular disease sooner or later. Yes, in other syndromes, in other disease, and in the first lecture about cardiovascular system, I told you that heart failure, be attentive, it's not a disease, it is a syndrome. It means that it always have some main cause. It can't be heart failure primarily like a disease. It's just a complication, it's just a result of something. That's why we name it just syndrome. It can't be a disease. And it have a huge number of causes. They can be cardiovascular and non-cardiovascular. And in cardiovascular disease, one more time, any cardiovascular disease, inflammatory valvular problem, congenital problem, arrhythmias, infarction, other types of ischemia, everything can lead to heart failure in early stages in form of acute heart failure or later in form of chronic congestive heart failure. But it can be complication of any cardiovascular disorder. Most often of them it is coronary artery disease, it is high blood pressure or hypertension, it is atrial fibrillation, valvular heart disease, excess alcohol use, infection or cardiomyopathy. In extra cardiac problem, it can be on first places, it is thyroid disease, kidney disease, diabetics, and heart defects present at birth. Risk factors. Yes, what risk factors are worsening prognosis of formation of starting of heart failure and worsening course of heart failure. Here on the first place, hypertension or constantly high blood pressure. It is coronary artery disease. It is heart attack, diabetes, some diabetes medications, sleep apnea, and congenital heart defects. It can be valvular heart disease. It can be some viruses, alcohol use, tobacco use, obesity, and irregular heartbeats and different arrhythmias. Clinical classification. In general, pathophysiologically, for understanding pathophysiology, what types of heart failure that it can be isolated left, isolated right, isolated systolic, isolated diastolic. We can classify it by cause, or it can be combination of different forms that goes with each others. For clinical evaluation of patient with heart failure, we use a specific clinical classification. One of the most usable in all world, it is classification of American College of Cardiology. Here you see this classification by stages. We name these stages A, B, C, and D. From different sources, they are a little bit other. You see that A, it is a high risk of heart failure but no structural heart disease or symptoms. Yes, it is asymptomatic high risk patients without symptoms, without anything, but with present risk factors of heart failure that we discussed in previous slides. B, it is presence of structural changes but no symptoms. It is still asymptomatic. It can be hypertrophy, patient with hypertrophy of myocardium, it patient with dilation, or for example post-MI patient without any symptoms of of heart failure. It will be stage B of heart failure. Be attentive with it. Stage C. In one classification, it is formulation structural heart disease with symptoms of heart failure. In another, it is left ventricle systolic dysfunction and symptomatic congestive heart failure. Yes, from stage C, it goes symptomatic. One more time, if you see just any symptoms of heart failure, is it dyspnea, is it edema, is it jugular venous pressure, it from the moment of symptoms it goes stage C. And stage D, it is end stage or refractory chronic heart failure. Usually this heart failure requires specialized interventions. It needs some surgical interventions. In cardiology, on 5 course, you will learn all of them. And one more clinical classification, how we defined severity of symptoms. Here, the most usual and the most usable classification in all world, it is classification of heart failure by functional classes, according to New York Heart Association. It can be 4 functional classes from 1 till 4. First functional classes. It is ordinary physical activity does not cause under fatigue, dyspnea or palpitations. It is no limitation of physical activity, just very severe activity, very hard training can lead to some symptoms. Functional class 2. It when the ordinary physical activity causes fatigue, dyspnea, palpitations or angina. We name it mild limitation of physical activity. Class 3 heart failure. It is comfortable at rest, less than ordinary physical activity causes fatigue, dyspnea, palpitations or angina. It is moderate limitation of physical activity. And the last functional class, it is functional class 4. When the symptoms occur at rest and any physical activity increases discomfort. It is severe limitation of physical activity. Clinical picture. What can we see most usual in heart failure patient? First of all, and most often, it is shortness of breath or dyspnea. Often it can be fatigue and weakness. Often symptoms swelling, edema in legs, ankles and feet. It is rapid or irregular heartbeat, reduced ability to exercise, persistent cough or wheezing with white or pink blood-tinged phlegm, increased need to urinate at night. Moreover, it can be swelling of abdomen, you remember we name it ascites. It is sudden weight gain from fluid retention. It is lack of appetite and nausea. It is difficulty concentrating or decreased alertness. It is sudden severe shortness of breath and coughing up pink foamy mucus. It is chest pain in heart failure and caused by heart attack. If we discuss specifically left or right symptoms, they are quite different. That's why according to type of symptoms in heart failure patient, you suspect what the initial chamber, what the problem at the right or at the left had this patient. Clinical picture of left heart failure. Dyspnea reflecting pulmonary congestion and fatigue reflecting low cardiac output. Dyspnea occurs during exertion and is relieved by rest, and as heart failure worsens, it can occur during rest and at the night, sometimes causing nocturnal cough. In paroxysmal nocturnal dyspnea awakens patients several hours after they lie down and is relieved only after they sit up from 15 to 20 minutes. In severe heart failure, periodic cycling of breathing chain stocks can occur during the day or night. Sleep-related breathing disorders such as sleep apnea are common in heart failure and may aggravate heart failure. Severely reduced cerebral blood flow and hypoxemia can cause chronic irritability and impair mental performance. The most common symptoms are ankle swelling and fatigue for right heart failure. If there was dyspnea on first place, here it is swelling and first of all ankle swelling. and fatigue. Hepatic congestion can cause right upper quadrant abdominal discomfort, and stomach and intestinal congestion can cause anorexia and abdominal bloating. Less specific symptoms include cool peripheries, postural lightheadedness, nocturia, and decreased daytime micturition. For the right heart failure, skeletal muscle wasting can occur in severe biventricular failure and may reflect increased catabolism with increased cytokine production. Significant weight loss, cardiac cachexia, is an ominous sign associated with high mortality. In the elderly, presenting complaints may be atypical, such as confusion, delirium, falls, sudden functional decline, nocturnal urinary incontinence, and sleep disturbance, coexisting cognitive impairment and depression. Here you see a scheme of clinical picture, left and right heart failure. One more time, for right heart failure, it is congestion of peripheral tissue that lead to edema, ascites, liver congestion, and impaired liver function, to GI tract congestion that lead to anorexia, GI distress, and weight loss. And on the other hand, left heart failure, decreased cardiac output, yes, systolic dysfunction to activity intolerance, signs of decreased tissue perfusion, cyanosis, and signs of hypoxia. It's more rare case, and the most often case, it is pulmonary congestion that lead to autopnea, cough with frothy sputum, and paroxysmal nocturnal dyspnea. Diagnostics of heart failure. In left heart failure, tachycardia and tachypnea, hypotension, and confusion became of hypoxia, and poor cerebral perfusion may occur. Central cyanosis reflects severe hypoxemia. Peripheral cyanosis of the lips, fingers, and toes reflects blood flow with increased oxygen extraction. Left ventricle systolic dysfunction include a diffuse, sustained, and laterally displaced apical impulse and audible and occasionally palpable third S3 and fourth S4 heart sounds. An accentuated pulmonic component P2 on the second heart sound S2. Pansystolic murmur of mitral regurgitation at the apex may occur. Pulmonary findings include early inspiratory basilar crackles that do not clear with coughing, and if pleural effusion is present, dullness to percussion and diminished breath sounds at the lungs bases. What is ACG? First of all, ACG is a not specific diagnostic for heart failure. We always do it, but it is additional method to diagnosing complications and cardiac structure in patient with heart failure. But according to ACG picture, you never can put diagnosis heart failure. But it is very informative for complication, like, and for example, arrhythmias, and most danger of them you see here. It is ventricular tachycardia in the upper strip, and in the lower strip, ventricle fibrillation. I show you this, the same ACG on a MI patient. Yes, it is very severe, clinically significant ventricle arrhythmias. Central cyanosis. Here you see photo of patient with central cyanosis. You see that all her skin have some blue coloration, and the most specific it is in the lips and in the end of in the peak of her nose. That is included in central cyanosis. It is caused by abnormal composition of hemoglobin, such as sulfahemoglobinemia and methemoglobinemia, or decreased in saturation of the oxygen. Because of cyanotic congenital heart disease, pulmonary embolism, pulmonary edema required urgent treatment, and severe respiratory disease. What is peripheral cyanosis? It when we don't see blue coloration of all skin, but we see blue coloration of distal phalanx of fingers. It can be blue coloration of ears. Peripheral cyanosis can be result of causes of central cyanosis and can occur in isolation or both with central like in previous patient. Common causes of peripheral cyanosis without central are peripheral vasoconstriction due to cold, Raynaud phenomenon, and beta blocker drugs. Reduced cardiac output due to cardiac failure or hypovolemia. It is peripheral vascular disease. It is venous obstruction, like for example deep vein thrombosis. Yes, auscultatory, we discuss what heart sounds it can be. And according to heart changes, it can be some valves problems, stenosis or regurgitations. It can be additional S3, S4 sounds, and it can be some murmurs. What about specifically right heart failure? Non-tender peripheral pitting edema, digital pressure leaves visible and palpable imprints, sometimes quite deep, in the feet and ankles. An enlarged and sometimes pulsatile liver palpable below the right costal margin. Abdominal swelling and ascites, and visible elevation of the jugular venous pressure, sometimes with large A and V waves that are visible even when the patient is seated or standing. In severe cases, peripheral edema can extend to the thighs or even the sacrum, scrotum, lower abdominal wall, and occasionally even higher, anasarca. Edema may be asymmetric if patients lie predominantly on one side. With hepatic congestion, the liver may be palpably enlarged or tender, and hepatojugular or abdominal jugular reflex may be detected. Precordial palpation may detect the left parasternal lift of right ventricle enlargement, and auscultation may detect the murmur of tricuspid regurgitation of the right ventricle S3 along the left sternal border. Both findings are augmented upon inspiration. Here you see a photo with peripheral edema. Yes, it is a swelling of ankles, swelling of lower legs, and we can check it for edema to push with your finger in this place of edema, and you see such symptoms can be lifted. And anasarca. Anasarca, it is a whole body edema. It is edema of all body. It is both extremities, upper and lower. It is ascites. It will be hydrothorax. It can be hydropericardium. It is swelling of all organs, all tissues, even face. Diagnosis. Sometimes it's only clinical evaluation, just clinical symptoms, edema, swelling, jugular venous pressure, cough can help you to put diagnosis heart failure, just symptoms without any additional information from any additional diagnostic tests. We can use visualization. It's usually chest X-ray, electrocardiography, echocardiography, cardiac radionuclide scan, and MRI. Sometimes laboratory do blood natriuretic peptide or brain natriuretic peptide or N-terminal proBNP levels. Other blood tests are not used for diagnosis but are useful for identifying cause of heart failure. Yes, we usually have do lipidogram, coagulogram, electrolytes level, a liver function test, kidney function test. Usually we do all of them for patient with heart failure, but we use it for determining complications, determining concomitant disease or maybe causes of heart failure, but they are not directly show us presence of heart failure. Other tests for etiology are needed. Clinical findings suggest heart failure but are usually not apparent early. Similar symptoms may result from chronic obstructive pulmonary disease or COPD, or recurrent pneumonia, or may be erroneously attributed to obesity or all. For heart failure should be high in patients with a history of myocardial infarction, hypertension or valvular disorders or murmurs, and should be moderate in any patient who are elderly or has diabetes. Chest X-ray. Its findings include an enlarged cardiac silhouette, pleural effusion, fluid in the major fissure, and horizontal lines in the periphery of lower posterior lying fields. It is specific sign of pulmonary congestion that we named curly B lines. The X-ray may also suggest alternative diagnoses, like chronic obstructive pulmonary disease, pneumonia, interstitial pulmonary fibrosis, lung cancer. On ECG, its findings are not diagnostic, we are told about it, but an abnormal ECG, especially showing previous MI, left ventricle hypertrophy, left bundle branch block, or tachyarrhythmias like rapid atrial fibrillation, increases suspicion for heart failure and may help identify the cause. The entirely normal ECG is uncommon for chronic heart failure, but what is very important, it is possible. Normal ECG does not exclude heart failure. Echocardiography or heart ultrasound can help evaluate chamber dimensions, valve function, ejection fraction, wall motion abnormalities, left ventricle hypertrophy, and peripheral effusion. Measuring left ventricle ejection fraction can distinguish between predominant diastolic dysfunction and systolic dysfunction. Intracardiac thrombi, tumors, and calcifications within the heart valves, mitral annulus, and aortic valve abnormalities can be detected. Localized or segmental wall motion abnormalities strongly suggest underlying coronary artery disease, but can also be present with patchy myocarditis. You remember that akinesia, or absence of wall motions, local, it is signs of post-MI patient first of all. Doppler echo accurately detects valvular disorder or shunts, can help identify and quantify left ventricle diastolic dysfunction. Here you see picture, it is 4-chamber view of echocardiography, and here you see dilation with abnormal diastolic function of left ventricle in congestive heart failure patient. It is Doppler echocardiography. You also know that coloration, it is blood flow, and here it is abnormal flow with aortic regurgitation jet that you see in the big orange zone. Here you see a big dilated left ventricle, and here you see intrachamber thrombosis. It is M regime of echocardiography, and according to these ways we can evaluate valve function. It is one more type checking of valve function. First 3 pictures, it is M regime, and last one in B regime. And according to echocardiography, we can classify diastolic dysfunction according to level of normal or abnormal mitral inflow with Valsalva. According to tissue Doppler and left atrial pressure, we can classify a type of diastolic and severity of diastolic dysfunction. It is checking of valves one more time during echocardiography. Radionuclide scan, we can use it, but usually clinically they used very rare. In some not understandable cases, it is second line diagnostics. But it can help access systolic and diastolic function, previous MI, and inducible ischemia of myocardial hibernation. MRI. Cardiac magnetic resonance imaging provides accurate images of cardiac structures and it becoming more widely available. Here you see pictures of MRI. Yes, if we have some questions, not first line 2, it is second line, but when we have some problems, some questions with the myocardial structure, maybe thrombi, maybe suspected tumor or something, other tissue changes, MRI it is a very good technique. What is NP and BNP and N-terminal proBNP levels? Serum natriuretic peptide and brain natriuretic peptide. This finding may help when clinical findings are unclear or other diagnoses, like in chronic obstructive pulmonary disease, need to be excluded. It may be particularly useful for patients with history of both pulmonary and cardiac disorders. Anti-proBNP is inactive moiety created when proBNP is cleaved, but be used similarly to NP-BNP. The Framingham criteria for diagnosing of heart failure. According to this criteria, diagnosis requires the simultaneous presence of at least two of the major criteria or one major criterion in conjunction with two of the minor criteria. Major criteria include the enlarged heart, NS3 gallop rhythm, auscultatory, acute pulmonary edema, episodes of waking up from the sleep gasping for air, crackles on lung auscultation, central venous pressure of more than 16 centimeters of water at the right atrium, jugular vein distension, positive abdominal jugular test, and weight loss of more than 4.5 kilograms in 5 days in response to treatment. Minor criteria for this Framingham study include an abnormality fast heart rate of more than 120 beats per minute, nocturnal cough, difficulty breathing with physical activity, pleural effusion, and decrease in the vital capacity by 1/3 from maximum recorded, liver enlargement and bilateral ankle swelling. Complications of heart failure. Yes, it is target organ can be in all body because the heart is responsible for oxygen supply of all organism, but the most sensitive and most danger of them it is encephalopathy. It is kidney damage or failure, heart valve problems, heart rate problems, liver damage, etc. And I promise you UMSMLE test. An 84-year-old male with history of severe emphysema and prior myocardial infarction becomes short of breath with exertion. Physical examination reveals a 3-6 holosystolic murmur in the cardiac apex and S3 heart sounds, and rails in the lower lung fields. No lower extremity edema is present. Which of the following is the likely diagnosis? A. It is left-sided congestive heart failure. B. Right-sided congestive heart failure. C. Left and right-sided congestive heart failure. And D. Cor pulmonale. Please, for yourself, after the listening of our today's lecture, try to analyze case from this question and answer for yourself. I don't need, it's not obligatory, it's just interesting activity to activate your knowledge that you got from this lecture. And for today, it was explanation of previous test. Here you see correct answer. For today that's all. From the next lecture we will start another symptom, and now please finish your syndrome of cardiovascular system. Be very attentive with heart failure syndrome. And good luck for you, good luck in your education, and see you next lecture. Goodbye.